Good morning. Very pleased to be here. I'm Bill Beckerman. I'm one of the vascular surgery residents. We're at Mount Sinai Hospital, and I've been privileged to be involved in a lot of very interesting cases through my time here. So I'll present two cases today. Nothing too crazy, but both a little unusual, and we can go through these slowly. So this first patient is an 84-year-old female, very extensive past medical history, which shouldn't be too surprising, with a greater than 5-centimeter juxtarenal penetrating aortic ulcer, actually presenting as a contained rupture. She was asymptomatic, and thankfully this was found on an annual surveillance axial imaging, even though the previous year's scan was entirely normal. She gets these scans because of her extensive history of malignancy, including breast cancer, endometrial cancer, renal cancer, et cetera. And if that wasn't enough, she also has CAD, COPD, and history of small bowel obstruction. Medications, as you see there. When we saw her in the office, she was stable. Abdomen was soft, non-tender. No pulsatile masses were felt. And she had nice, brisk, bounding, palpable peripheral pulses. Labs, again, were unconcerning. White count was normal. Measures of inflammation were also normal as well. So this was from, actually just this past year. CTA, after her prior surveillance, revealed this pararenal PAU, which we'll see here. So we'll come down slowly. And as we can see, right around the renal arteries, obviously this extravasation, ulceration of the outside the aorta, not entirely normal. We'll go back and see that again after we come down. So again, unfortunately, very few people present with a, nice, infrarenal contained rupture. They all have to be right around the visceral and renal vessels. So right here, right at the level of the renals, we can see this extrav in the posterior portion of the aorta, making any repair a little bit more complex than would be desirable. We'll see this again from a sagittal view, and this will give kind of a better idea of how difficult this repair might be. And we'll pause it right here and go through it slowly. So you can see the celiac and the SMA coming off right here. And it's pretty much right in line, and you can actually see the defect in the plaque at the posterior wall of the artery. And then all this contained rupture right there, just anterior to the spine. So as might be expected, given her age, CAD, COPD, previous transabdominal and retroperitoneal surgeries, she is suboptimal for any sort of open aortic surgery. Additionally, she has no infrarenal aortic neck for a traditional EVAR, so any repair must take into account both the renal as well as the visceral vessels. And also, in contrast to your normal patient with an infrarenal AAA, this is an isolated phenomenon. Her aortic lumen is too narrow for fenestrated EVAR or P-branch grafts. We can use chimney parallel grafting. It has to take into account the renal arteries and the SMA, plus or minus the celiac that may or may not be involved. So putting this along a short length of Viabon might be an option. Additionally, however, given all the different parallel grafts that have the potential to be in the same space, there's a very real possibility that we might actually occlude the aortic lumen, and there's the possibility that the patient might need an AX bifem. Sure. So before we go into anything, I guess we can open up the floor and see what people would do for this very interesting pathology. The floor is very quiet, Dr. Raven. I guess people are just waking up.
So any idea?
Well, there are a number of things that come across my mind. Some are sane, some are
Hasn't stopped us before at West.
yeah, I think, I question whether or not you actually have enough lumen for chimney or parallel grafting. I mean, if you're thinking
Myself, probably a bare metal stent and fill the sac with coils or something like this. That's a really tough case, you know. I can say that, I mean, the aorta looks very narrow at the level of the rupture also. So it's a difficult case.
Yeah, and she was a tiny lady as well.
Situation
Yeah.
in the past, we also implanted a multi-layer stent there and filled the sac. But I don't know if it's a good option.
Is there, when you're looking at filling the sac, I mean, because that would have been a nice and elegant solution, my concern is, do you worry if it's not a narrow neck to this thing that you're just still having indentation and it still could rupture, or, I mean, that's my concern, is that it looked like there's a fairly large neck in that area, lack of neck, it just seemed to be kind of flowing into the area of the PAU. When the coils really, it makes the picture, oil fill it so bright, not be able to see anything. Does that, have you seen patients that it tends to seal up and heal over, or what have you seen with putting coils and things like that?
We had only a few cases done in the past. I know that it works immediately, but I don't have a follow-up for these patients. Very seldom.
Well, Bill didn't want to do that, so.
So we'll go forward with what we actually did. So as you might have seen at the beginning, so we actually did end up doing the parallel grafting with using a Viabond as our main aortic piece. So we got initial access. And very easy to see the defect that we saw on the CT scan right here running posteriorly. And we get a little better view right here. Again, not a subtle finding. So it confirms the posterior rupture at the level of the renals. At this point, we did a left axillary cutdown and created a 10 millimeter Dacron conduit. We advanced a 7 French sheath into the aorta, and we cannulated the left renal with a floppy glide wire and angled glide cath, which is fairly standard in terms of our the initial tools we'll use. And we exchanged this for a Rosen stiff wire, and we advanced the sheath into the ostium. Again, this is coming up from above the axial conduit, and we're now in the ostium of the left renal, as we see here, good filling. This is our Rosen wire. And we pretty much did the same thing for the SMA. And then the right renal. So at this point, we have all of our Rosen wires in the vessels that we think we may need to protect for this procedure. And we have good filling of everything. At this point, we use 6 millimeter ICAST stents over the wires. We needed to confirm that the proximal stents were below the celiac, and we also needed to make sure that we had enough length on our Viabond covered stent graft to make sure that we would exclude the entirety of the PAU. So you can see the top ends of the stents. I have all right here. We see SMA, we see celiac, and it looks like we should be able to get enough seal zone in this area between the, right below the celiac artery to not have to cannulate and also protect the celiac as well. At this point, we deployed the renal as well as the SMA stents. 1, 2, 3. These are all lateral views, by the way. And then we deployed a 13 millimeter, I think that's the largest they manufacture, Viabond stent, and did our, what we thought might be a completion angiogram. We were proven wrong. And looks good, and then you see, oh, there we go. So need a little more coverage there. There's a good amount of extrav still, so we probably need to extend down and balloon all of our overlaps as well. So we put in another, at this point we put our stiff balloons in all of our parallel stent grafts. and then extended down. So our completion angiogram after that shows good filling of the right renal, left renal, SMA, and no extravasation, into the penetrating aortic ulcer. She had no major issues postoperatively. This was all done percutaneously in the groin with a small conduit at the left axilla. She was actually discharged post-op day 1, baseline status, ambulating with good urine output and baseline creatinine. And the postoperatively showed all patent stents, no evidence of endo leak. Have you seen her recently, Dr. McKinsey? Doing well?
Basically no flow in the so scientific flow is all good.
Yeah, it's good. Despite all these comorbidities, she was a very vivacious, very active person. You'd see someone on paper and you see someone in person, 2 entirely different people. So it was very good to hear.